Hello, my name is Miriam Hernandez, and my virtual poster is titled Ovarian Preservation Compared to Oophorectomy in Premenopausal Women with Early Stage Low Grade Endometrial Cancer, a Cost Effectiveness Analysis. Endometrial cancer is the most common gynecologic malignancy in the United States. It is estimated that 65,620 women were diagnosed with endometrial cancer in the United States in 2020, reflecting an increase in the incidence of endometrial cancer of 24 per 100,000 women in 2000 to 28.4 per 100,000 women in 2017. And the incidence is projected to exceed 40 per 100,000 women by 2030. Specifically, the incidence of endometrial cancer is increasing in women between 30 and 40 years old. Most young women are diagnosed with early stage, low grade disease, which carries a good prognosis and can often be cured with surgical treatment alone. Standard surgical treatment includes a total hysterectomy with bilateral salpingo oophorectomy and possible lymphadenectomy in women at high risk for nodal disease. The ovaries are removed for three reasons. One, to remove adjacent site where metastatic cancer can occur. Two, to remove a potential site for synchronous ovarian cancer. And three, to remove a source of endogenous estrogen. However, removal of the ovaries results in surgical menopause in young women, which is associated with more severe menopausal symptoms compared to natural menopause, cardiovascular disease, osteoporosis, sleep disturbances, depression, and neurologic disorders, leading to increased mortality and decreased quality of life. Recent evidence supports the oncologic safety of ovarian preservation in premenopausal women with early stage low grade endometrial cancer to help prevent the short and long term effects of estrogen deprivation. One important disadvantage is that ovaries can hold occult metastatic or synchronous ovarian cancer or be a potential site for recurrent endometrial cancer or future ovarian disease. These events are rare among young women with early stage low grade endometrial cancer, especially if they have normal appearing ovaries intraoperatively. Over the past decade, there has been a gradual increase in the utilization of ovarian preservation at the time of surgical treatment. The object of this study was to determine whether oophorectomy or ovarian preservation was a cost effective treatment strategy in premenopausal women with early stage, low grade endometrial cancer and normal appearing ovaries. The methods we designed a decision analytic model using Triage software using a theoretical cohort of 10,600 women to represent our population of interest. The model inputs were derived from the literature, and the willingness to pay threshold was set at $100,000 per quality. Sensitivity analyses were conducted to evaluate the robustness of the results. This here shows an outline of our final tree. If we look at the first branch point, the oophorectomy arm is located at the top and the ovarian preservation arm is located at the bottom. For our results, we found that ovarian preservation resulted in lower costs and higher qualities, making it the cost-effective treatment strategy where compared to oophorectomy. In our theoretical cohort of 10,600 premenopausal women with early stage, low-grade endometrial cancer, oophorectomy resulted in 25 more cancer recurrences, as we can see on the table on the right where the difference column is at. It also resulted in 149 more deaths and 1,712 more cases of vaginal atrophy. Meanwhile, ovarian preservation resulted in 101 cases of ovarian cancer. Sensitivity analysis identified the probability of developing ovarian cancer and the probability of endometrial cancer recurrence after ovarian preservation as the most impactful variables in our model. This means that changes to these two variables had the potential to change the outcome of our model. Ovarian preservation stopped being cost effective when the probability of developing ovarian cancer surpassed 16.7%. Meanwhile, oophorectomy became the dominant treatment strategy when the probability of cancer recurrence after ovarian preservation surpassed 6.2%. The graphs of the one-way sensitivity analysis can be seen on the left. Figure 1 demonstrates how the ICER changes according to changes to the probability of developing ovarian cancer. Meanwhile, Figure 2 shows how the ICER changes according to changes to the probability of cancer recurrence after ovarian preservation. Located on the x-axis is the model input of interest, while the ICER is located on the y-axis. The willingness to pay threshold of 100,000 per quality can be seen in Figure 1 and is marked by a horizontal black line. In conclusion, ovarian preservation is a cost-effective treatment strategy when compared to oophorectomy in premenopausal women with early-stage low-grade endometrial cancer who have normal appearing ovaries intraoperatively. Ovarian preservation should be considered in this group of women to prevent the short and long-term sequelae of surgical menopause. Most of the data in our model inputs were based on retrospective studies, which introduces a level of selection bias into our results. Notably, the probability of cancer recurrence comes from a retrospective study where women who underwent oophorectomy had higher grade disease than women who had their ovaries preserved. As a result, the probability of cancer recurrence after oophorectomy was higher than ovarian preservation at 2.51 versus 2.71%. It would be helpful to have more randomized controlled trials and prospective studies to get more accurate model inputs. Furthermore, there is limited data regarding the use of estrogen therapy in young women with early stage low grade endometrial cancer to help mitigate the long term effects of estrogen deprivation. We did our best to draw assumptions from the literature, but the impact of estrogen therapy after oophorectomy in young women will be difficult to define without further research. Despite the limited evidence on this topic, our study suggests ovarian preservation is the cost-effective treatment strategy for premenopausal women with early-stage, low-grade endometrial cancer and should be considered to prevent the negative consequences of surgical menopause. Thank you so much for listening to my presentation, and I would like to thank my mentors, Dr. Monroe, Dr. Briegel, and Dr. Coy for helping me with this project. Thank you.